Hello everyone. In our series of Docplexus interactions, today we have with us Dr. Sonia Malik, who is a renowned gynecologist and IVF specialist. She is the director of South and Fertility and IVF and has more than 36 years of experience in the field of IVF. So we would like to ask some questions, and the first question that we would like to ask is that there's a lot of dilemma in physicians as well as in patients regarding the first step of infertility about the treatment. So what would be your suggestions or the brief guidelines that one should adopt for the infertility treatment starting?
Hi everyone, this is Sonia Malik and welcome to this series. As she said, you know what, basically as per the guidelines, we are concerned about the status of ovulation, the status of the man, as well as the status of the tubes. These are the three cardinal features for infertility management. But of late, what we are finding is that because of an increase in the age of marriage, because of women pursuing their careers, because of women being more conscious about themselves and not getting into a situation where they are saddled with a child. In such situations, what happens is they are postponing their pregnancies. Hence, according to me, and according to the shifting or the new guidelines as well, ovarian reserve or even a man's reserve forms the biggest problem and should be handled first of all. Before we think of anything else, it is the age of the woman and her ovarian reserve which has to be talked about first of all to the couple. Because if they don't have their own ovarian reserve or their own spermatic reserve, as I would say, then what happens is they'll land up in a very large, very big problem. So basically, rather than looking at the guidelines or rather than looking at what has been suggested all these years, I think there has been a shift in the type of patient that we are getting. Hence, we need to look at these problems much more than looking at the standard problem that we have been talking about all these years.
So, you'd request to tell us the indications that suggest the shifting of a patient from IUI to IVF, and is there a limit to hyperstimulate the ovaries?
Okay, so now we are getting on to a different area. First of all, it was infertility, which is of course the investigation and diagnosis of infertility, and then we are shifting to the kind of treatment that we are wanting to offer. Is it going to be as simple as an IUI? Or is it going to be something more complex like an IVF? So basically, many of you would be aware of this, that now all infertility services are offered both to the infertile couple as well as to the fertile population. So it's not just restricting ourselves only to the ones who are basically not able to conceive, but also to some people who are postponing their pregnancies, as I mentioned in the first instance. So therefore, the indications of infertility management have changed. So let us take IUI first of all. So IUI is a very simple procedure, and it only entails the deposition of processed sperm into the woman's body. Whereas IVF, on the other hand, means that you are extracting the eggs of the woman out of her body, mixing them with the sperm, and then putting them back into the body of the woman. So basically, for the first thing, you can practically do it for all kinds of indications where the tubes are open. So primarily in IUI, the first requirement is that the tubes should be open. Hence, the indications would be, if the woman is not ovulating properly, you are inducing ovulation. If there is a mild male factor, if there are diseases like polycystic ovarian disease or endometriosis, or the patient is suffering from unexplained infertility. Whereas for IVF, the indications are limitless. All these patients can be shifted to IVF if they don't succeed after an IUI. And in addition to that, you have patients, like I said, who are postponing their pregnancies, or a big segment of patients who are suffering from cancer. So even in cancer patients, we are able to preserve the eggs or the embryos of the woman as well as the sperm of the man. So that when they are treated and when they are cured of their cancer, they can come back again to have a child out of the gametes that are frozen or out of the embryo that is frozen. Hence, today IVF is extended beyond infertility to even fertile couples. So the indications have changed, and as I explained, IUI has a different segment and IVF has no limit. Anybody can come and get an IVF done.
Thank you for explaining it so nicely. So, this cost associated, and plus there is a complete procedure to go for this therapy, and there are then psychosocial issues associated. So it becomes very difficult for the physicians to deal with the patient expectations and the pre-therapeutic commitments that are associated with this therapy. So what would be your advice to the physicians to deal such situations?
I think the biggest problem with this speciality or with this treatment is, like you said, the expectation of the patient is much, and we cannot guarantee 100% success. Contrary to the other segments of medicine, where if there is a problem with the gallbladder, they remove the gallbladder, so the patient is cured. And so also with other surgical problems, once you do a surgery, things become all right. But here is a situation where you are making them go through a process which is so elaborate, and at the end of it you can't guarantee 100% success. Hence, the patient feels dejected, patient feels very upset. The first question that a patient asks us is, what is your success, and how are you going to guarantee a success to us? So for that reason, yes, my advice to the physician will be that you have to be upfront with the patient, no matter what it is, whether your success rate is 20% or 10%, say of a procedure, it is only 10%. Looking at the age of the patient, she comes to you at age 40 and she's expecting 100% result. It's difficult. So you have to be upfront with them and tell them what is the reality. Make them understand what their problem is and why we are not able to deliver what we are trying to promise to them, so that they don't feel upset at the end of it and they don't come and tell you कि हमें तो आपने बताया ही नहीं था, ये ऐसे कैसे हो गया. So that is our biggest challenge, to be able to counsel the patient in such a manner that they don't feel that they have been cheated. The biggest success of an IVF clinic or an IVF physician is that a patient who has failed in her IVF center should come back to her for another IVF cycle. So when we have returning patients to us, even after we have not succeeded, I consider it as my biggest success. And when a patient who has failed goes and talks well about you in another center, or goes and talks well to other patients, that is your biggest success. Hence, you have to be so good in counseling them and telling them about each and every step of the procedure that they don't feel cheated at all.
Talking about success, Dr. Malik, would you like to share any toughest case that came across your practice, or any different kind of case that you'd like to share?
I always remember this young girl who came to me when she had not started with her period. And her mother brought her along saying that she's now 16 and she doesn't have a period. And when we examined her, we found that she doesn't have a uterus. So, it was very shattering for the family, and they came from a rural background of Haryana. So you can imagine, but fortunately the parents were very well educated. Hence, they understood the problem that she's not going to be able to have children of her own. So, I beg your pardon, it was not uterus, it was ovaries. She didn't have ovaries, she had a uterus. But the uterus was underdeveloped and she was an unmarried girl, so we gave her hormones to develop her uterus. And we explained very well to the parents that she's not going to be able to have children who are going to be her own genetic children, but she can always have children with donor eggs. That means third-party reproduction is always available to her. So as time passed on, the parents were very, very good, and they got her married to somebody whom they knew, and he was explained the whole thing. He was told that she doesn't have ovaries and that she would be needing donor eggs. And then later on, her sister donated eggs for her, and so we were able to give her a child. She conceived, she had a son, and then after that she wanted a second one. So out of the frozen embryos, after 3.5 years or maybe 4 years, she had another son. So I consider this as quite a miracle, because today science is, we are able to complete her family out of her own genetic pool, because the eggs were donated by her sister. They may not be her, but they were her sisters. And then now today she's a mother of 2 children and happily married. Nobody in the family knows that she doesn't have ovaries and that the children are not hers genetically. But this is what I consider. It's not a difficult case. There would be so many IVF specialists who would have done the same thing. But I think it is very gratifying for us to be able to be dealing with patients like this, where there was no hope about 25 years ago. Nobody could ever think that such a child could ever bear a child. So she's been with me for the last 20 years, and I have seen her through this journey of not getting a period, then becoming a proper normal human being, where she's menstruating every month with the help of medicines, and then having 2 children of her own. I think this is a great journey that she's had. So today she's a very satisfied young mother.
Great. So we congratulate you for that, and we are really happy for such families whom you made hopeful and then succeeded for the same. So the last question that you like to ask is, being a member of Docplexus community, what is your take on the prospect of such professional community of doctors?
I think it's a great initiative, and I think it is very much required. It needs to be more popularized. And I feel, you see, because what happens is we are only talking about the metros where everything is available, and we are able to access everything because we have meetings like this, and we have fora where we can sit with each other and chat and discuss. But what happens to the doctor who's sitting in a very small center, in a small place, where he or she has got no access to libraries, to journals? And there to be able to access through the internet is a great thing, because internet is available everywhere. And, I would liken it to a farmer, So about 10-15 years ago, the farmers knew nothing about what is happening to the agricultural status, to the seeds, to the climate, to the weather conditions. Now, anywhere in a small village with the mobile phone, he has access to everything. So also a doctor. So basically, our profession needs much more information and much more data in order to be able to help the patient and in order to be able to serve communities. And in far-flung areas where there is nothing available, I think this is a great initiative where at least we can exchange our thoughts with our own colleagues who don't have access to anything. I have been using this a lot, this internet, this platform, because I feel that this is the only way that we can stay connected without even moving out of our houses.
Great.
And clinics.
Thank you so much, ma'am. We are really grateful to you, and thank you for sharing your valuable time. We hit you in your busy schedule, but thank you so much.
Thank you for giving me this opportunity. Thank you very much. Thank you.
These interviews and videos are brought exclusively for the members of Docplexus community. To stay updated about such upcoming events, we would request you to subscribe to our YouTube channel, like our Facebook page, and follow us on Twitter. Happy Docplexing!